So the traditional paradigm of IBD pathogenesis is centered around chronic inflammation and mostly around lymphocytes and in particular T cells. However, having this narrow view of the pathogenesis of IBD may miss some important events that take place during acute flares of the disease or during the early stages of the disease, as Dr. Francesco already alluded to before. During these acute events, the most important cell population at the intestinal mucosal is that of the innate immunity, mostly granulocytes, monocytes, eosinophils, and cells of the innate immunity in general. And also, likewise, our therapeutic approach to IBD has been traditionally, again, aimed against T cells and lymphocytes in general. And so nowadays we aim at two areas. The first, to block the recruitment of inflammatory cells towards the inflamed mucosa by the adhesion processes. And secondly, to neutralize the pro-inflammatory cytokines that are secreted by these inflammatory T lymphocytes. However, some recent studies point to a different view of action of these drugs. Let's for example, take this study for an example. Vedolizumab is a prototypical anti-lymphocyte treatment that we use in IBD because it blocks the recruitment of T cells. However, when this German group looked at the effect of vedolizumab on the immune phenotype of patients, they saw that the effect was major in innate immunity rather than adaptive immunity, as would have been expected. So we have to keep an open mind at the broader view of the immunopathogenesis of IBD and the effect of the various medications. For example, we first have to remember that neutrophils, like the lymphocytes, they also recirculate. They are attracted to sites of inflammation by use of several adhesion molecules and chemokines that Dr. Francesco already mentioned before. And one effect of the Adacolumn is that it may block this trafficking of neutrophils, this recruitment towards the inflamed mucosa. There are already some studies that adhesion molecules like ICAM1 or VCAM1, which are important for recruitment of cells at the intestinal mucosa, are downregulated after GMA. And also when the chemiotactic activity of granulocytes after exposure to the cellulose beads was studied, it was clearly seen that it goes down. So these granulocytes cannot move so efficiently towards triggers like complement factor 5 or interleukin-8, which is a chemiotactic factor secreted by epithelial cells when they are damaged, and they invite neutrophils at the site of damage. Which brings us to the importance of neutrophilic infiltration in everyday clinical practice. Here are the two major scores that we use for histological classification of IBD, the Geboe score and the Robarts histopathology index. And as you can see, in both of these indices, neutrophilic markers account for the largest percentage of the scores. And if we also look at the Nancy index, which is another validated index for the severity of inflammation in UC, not only neutrophils account for the inflammatory changes, but they also dictate the severity of inflammation, which means that the more neutrophils you have in the intestinal mucosa, the more severe is ulcerative colitis. And in further studies, it was actually shown that the presence of neutrophils in the intestinal mucosa has also prognostic value for the further clinical remission or relapse of the disease. This is a meta-analysis, and they checked at various histological markers to see which one would predict the clinical relapse in the medium and long term. And as you can see here, neutrophils in the epithelium, neutrophils in the lamina propria, crypt abscesses, which also reflect the function of neutrophils, and eosinophils in the lamina propria, all of these factors were positively correlated to the possibility to remain in clinical, to have a clinical relapse in the long term. So they are of prognostic importance, and actually these findings were further validated in this study, which actually showed that the presence of even a small number of neutrophils in the mucosa was associated with adverse outcomes. In this occasion, the need for use of systemic corticosteroids or hospitalization. So the presence of neutrophils is of importance, is a negative predictor for the severity of the disease, is a negative prognostic factor for the long-term outcome, and it follows that it would be a good thing for our patients to remove these neutrophils from the inflamed mucosa. And in other studies, it was further shown that the ratio of neutrophils to lymphocytes could be used as a biomarker which predicted the presence of mucosal healing. So in these two studies that are very recent studies, they looked at the association between the neutrophil to lymphocyte ratio in the peripheral blood in patients with ulcerative colitis. And what they actually saw was that the people who had more severe lesions, they had the highest ratios of neutrophils to lymphocytes. And more importantly, when they looked at these markers at baseline, people who actually, patients who actually achieved mucosal healing after 1 year were those that had the lower ratios of lymphocyte of neutrophils to lymphocytes. So it is a predictive marker, and this further emphasizes the importance of Adacolumn, who efficiently depletes neutrophils and also increases the number of lymphocytes in the peripheral blood, so normalizes this neutrophil to lymphocyte ratio. And another indirect evidence for the importance of neutrophils is the importance that fecal calprotectin measurements have in everyday clinical practice. We know now that fecal calprotectin is the best surrogate marker of intestinal inflammation that we have available in clinical practice, and this is why we use it more and more in our patients and in our everyday clinical practice, because it reflects the disease activity in IBD so nicely. And in fact, the updated STRIDE recommendation clearly says and suggests that we should aim at getting calprotectin down to an acceptable range, which is usually less than 250 micrograms per gram of feces, in order to have better long-term outcomes in our patients. And there is this interesting study which actually indicates that GMA by Adacolumn may fit well in this treat-to-target paradigm in IBD. So in this study, they had 60 patients who were all in good clinical remission. However, they had elevated fecal calprotectin above the limit of 250 micrograms per gram, which means that they were at high risk for clinical relapse. And they divided this group of patients. Half of them were subjected to apheresis by Adacolumn, and half of them were the control group. And as you can see, at the end of 6 to 8 months follow-up, 1/3 of patients in the control group were in clinical remission, whereas 3/4 of patients, almost 73% of patients, responded well to apheresis and did not get a clinical relapse. So removal of neutrophils by Adacolumn has also this predictive, this good prognostic effect according to the current treat-to-target paradigm. So I think because this quick webinar is about ideal targets, I think neutrophils is an ideal target in IBD. So if we remove them from the intestinal mucosa, this is to the benefit of our patients. The issue is, can we achieve that with Adacolumn? And let me now go back to some immunology of IBD in relation to the neutrophils. Already Dr. Frances talked about the netosis in IBD. And I think we can summarize by saying that granulocytes in IBD are important. They are increased in number. They have an activated state, and also they are resistant to apoptosis. So the ideal treatment regarding this aspect of IBD would be a medication or a technique that would decrease the number of innate cells, remove the activated and replace them with deactivated cells, and also induce apoptosis again so they can be removed from the area of inflammation. And I think that Adacolumn efficiently does all these three things. It decreases the number of granulocytes, but even more importantly, it redistributes the composition of granulocytes towards a more immature and anti-inflammatory phenotype, and also it induces apoptosis as it was shown in this study. But the effect, it doesn't stop in neutrophils, and we know now that there are several populations of monocytes, some of which are pro-inflammatory and some of which are anti-inflammatory. And again, the Adacolumn, it was shown that it decreases the pro-inflammatory fraction and increases the anti-inflammatory fraction of monocytes, which also is of importance. And also the effects can also be extended to adaptive immunity pathways. Dr. Frances already talked about the Treg expansion, but there is also expansion of B regulatory cells as a response to the presence of apoptotic cells, which are phagocytosed by B cells, and then these B cells become avid IL-10 secreting cells, and we all know what regulatory effect the IL-10 has for the intestinal mucosa. And finally, and I think this is a very important aspect of the Adacolumn, is that the cells that are adsorbed at the Adacolumn, they release some factors, soluble factors, such as the TNF receptors 1 and 2, or the interleukin-1 receptor antagonist, or the hepatic growth factor. And all of these cells, when they are, all of these substances, when they are in a secreted form, in a soluble form, they act like decoy receptors, which means that they act in an inhibitory way. They trap their ligands and they prohibit the signaling, the downstream signaling. So again, this is an added anti-inflammatory effect of the Adacolumn. And we cannot talk about IBD pathogenesis nowadays if we don't mention the microbiome. And we know that the most stable, the most constant abnormality that IBD patients have in regards to the microbiome is a low bacterial diversity as compared to healthy controls. And this is considered the most intense paradigm of dysbiosis in this population. Now, there is one study, very recent study, published a couple of months earlier this year, which actually says that after GMA, the diversity of the patients is increased only in responders, which means it has to do something with the selectivity of the response. It is increased, and it's actually to the level of healthy controls. So this is another important aspect of Adacolumn. Now, one would raise the question, okay, so Adacolumn changes the peripheral blood granulocytes, but the problem in IBD is at the intestinal mucosa, not in the peripheral blood. But there are studies that show, and Dr. Frances already mentioned some of them, and I will remind two more to you, which actually looked at the pro-inflammatory cell population at the mucosa before and after GMA. And as you can see here, cells that secrete interferon gamma and cells that increase TNF, secrete TNF, are down regulated, are decreased after GMA. And the end result of all these effects is finally, in a subset of patients, all these pro-inflammatory factors are removed and they accomplish mucosal healing. So this is a webinar about ulcerative colitis, but I have to just make a notice here that the effects of Adacolumn are not only relevant to UC. They are also relevant to patients with Crohn's disease. They're relevant to patients with extraintestinal manifestations, because we know that there are shared cellular populations between the intestine, the skin, and the joints. So by removing these populations, you can fix the problem in various positions of the body. You can combine it with other biological therapies. I'm sure that we're going to talk about it later on. And also, the issue of safety makes it a suitable treatment for high-risk groups. So to conclude, I think that we all understand and we all accept that there are several dysregulations of innate and adaptive immunity pathways in IBD, and the effect of Adacolumn is relevant to many of these pathways. It removes pro-inflammatory cells, it generates anti-inflammatory substances, it generates regulatory B cells and T cells, and also it blocks the chemotaxis of inflammatory cells. The end product of all these various effects is a reestablishment of an anti-inflammatory microenvironment in the patients with IBD, which hopefully will lead to their clinical improvement. And with this, I thank you very much for your attention.